Today I would like to discuss about investigation on newborn. Investigation of cord blood sample from Rh-negative mother plays an important role in the management of HDN. A sample of venous blood taken from the infant after birth, even 30 minutes, is far less valuable than cord blood sample in assessing the severity of HDN. Cord blood sample should be obtained from the maternal side of the umbilical cord by inserting the needle attached to a syringe into the umbilical vein. One sample should be taken into anticoagulant ADTA. It is used for the ABO and Rh grouping, antiglobulin test, and for measuring hemoglobin value. The second sample is taken in a dry plain tube and serum is separated, which is used for the determination of bilirubin and antibody screening. Investigations on newborn include 1. ABO grouping, 2. RHD grouping including weak D, 3. DCT, 4. Screening and identification of antibody in cord's serum, 5. Hemoglobin estimation on cord blood, 6. Cord blood bilirubin estimation, 7. Hematological parameters on cord blood. 1. ABO grouping. ABO grouping on the newborn is based only on cell grouping because alloantibodies in the cord blood are of maternal origin. Red cells should be washed 4 to 5 times to avoid false positive results due to Wharton's jelly. Rh grouping. Accurate Rh grouping may be difficult if red cells are heavily coated with IgG antibodies. Either false positive or false negative result may occur. 3. Direct antiglobulin test. DAT usually gives strong positive results in HDN due to anti-D or antibodies to other red cells antigens, while reactions are much weaker or negative in HDN due to ABO. If the DAT is positive and the maternal serum has a negative antibody screening test, suspicion falls on ABO-HDN or HDN due to antibody not present on screening cell panel. 4. Identification of antibody from cord blood. The maternal Rh antibody may or may not be found in the infant's serum. However, identification of the antibody can be performed in the elute of cord cells. 5. Cord hemoglobin value. Cord blood hemoglobin correlates well with the clinical severity of HDN. The cord hemoglobin levels serve as a guide to assess the severity of HDN. Normal cord blood HB is 18.6 to 19.6 GDL. HB over 14 GDL fetus unaffected, HB 14-11 GDL mild to moderate, HB 8 to 11 GDL moderate to severe, HB below 8 GDL severe HDN. 6. Cord blood bilirubin. There is also a correlation between cord bilirubin concentration and severity of HDN, but it is less close than the cord hemoglobin. Cord bilirubin concentration is valuable to assess the severity of disease when HB value is within normal limits. Normal cord bilirubin is 0.7 to 3.1 in GDL. Cord bilirubin above 4 mg per DL is unusual and suggests very severe disease. Bilirubin levels are usually reached by the 3rd or 4th day of life. Antenatal management of Rh immunization. If after taking into account the mother's previous obstetric history, the level of anti-D, and the amniocentesis findings, the obstetrician is convinced that the fetus might not survive a full-term pregnancy, the following options are available at present. 1. Intrauterine transfusion. A. Intraperitoneal transfusion. B. Intravascular transfusion. 2. Premature induction of labor. 3. Plasmapheresis. 4. Intravenous immunoglobulin. Postnatal treatment of infant. About 40% of infants born with DCT-DAT positivity require no treatment, while others, if die within a few hours due to cardiac failure or become deeply jaundiced and may develop at any stage after the age of about 36 hours. It is desirable to select at the earliest cases of HDN treatment. 1. Blood transfusion. Exchange transfusion.